Good afternoon, everyone, and welcome to Fluid Frenzy. My name is Shelly. I will be your tutor for the next half an hour as we explore a little bit more about electrolytes. Just a couple of things to make you aware of. There is a Q&A box that's available, so if you have any questions throughout our presentation today, put those questions in the Q&A box. Jennifer is here and will be answering those questions for you. Please be patient. There's only one of her, and there's close to 100 people on, I believe, over 100. We've got a big group today. So those questions can go in the Q&A box. We are not going to be using Slido today. So for the questions that I ask you, you can use the chat box, and that's where you and I can communicate throughout the next half an hour. Um, Before we jump into those fluids and electrolytes too much, I would just love to find out where you're calling from. So just tell me in the chat box, where are you calling from? We have students all over the world, so it's kind of fun to see what we've got. North Carolina, Texas, Hawaii, New York, Pennsylvania, Canada, California, Connecticut, all over the United States. There's one from the UK, Chicago, Nigeria, Philippines. Yeah, we usually get a handful, Kenya, handful from out of the country. So that's exciting. Welcome, everyone. I'm glad to see you here as we spend the next half an hour talking about fluids and electrolytes. I would love to find out how you feel about fluids and electrolytes. Maybe use a 1 to 5 scale where 5 is I am so good at fluid and electrolytes, I absolutely understand it, and 1 is I have no idea what's going on. Tell me where you're at in that 1 to 5 scale as we're getting started today. I see a lot of 2s and 3s. That is pretty common. I think that's where most of you are. If you were a 5, you might not be here today. But hopefully we can bump that up just a little bit today and help you feel just a little bit more comfortable with your fluids and electrolytes. Now, obviously, in half an hour, we are not going to be able to cover everything you need to know about fluids and electrolytes. But we're going to hit a couple of important things. Today, we're going to talk about 2 electrolytes. We're going to hit the 2 that are most likely to show up on the NCLEX and that are often considered the most important electrolytes in the body. Tell me in the chat what 2 electrolytes you think that might be. The 2 that are often considered the most important. Sodium and potassium. You guys are great. That's the answer I am seeing from everyone. You guys are spot on. We're going to talk about sodium and potassium today. Give you that little introduction into 2 of those electrolytes that you have got to know and understand for your NCLEX. So let's start out with sodium. Sodium is the most abundant extracellular cation in the body. A couple things I want to point out there. Extracellular means that it primarily exists outside of the cells in the blood. And so that's why our sodium numbers are kind of high, 135 to 145. That shows us it is a high level in the fluids in the body. It is a cation. That means it has a positive charge. Na has that little positive next to it, and that makes it a positive cation. Cations that are positive cations are attracted to negative anions. And chloride is the one that we most often see with sodium. Chloride has that negative charge. We see those together quite frequently. NaCl, who can tell me what that is? NaCl is your basic table salt. Yes, Sonia, basic table salt. And so that is quite often where we see sodium. Yes, somebody asked about slides for today's presentation. I posted that link at the beginning of the chat. I will post it again at the end of the chat. And so all of these slides will be absolutely available to you. All right, sodium's job is to regulate water in the cells of the body. Water likes to crash sodium's party. So anywhere that there is a high concentration of sodium, water comes to crash that party. Water comes to balance it out. We know our body likes to be balanced. And so it sees that high sodium, sends water in to kind of try and dilute it and balance things out again. So anytime we have high levels of sodium, we are going to see water coming along to try and balance things out. Sodium is most important in the brain, the nerves, and the muscle cells. And so as we talk about sodium today, be thinking about how it affects the brain, how it affects the nerves, and how it affects the muscles. All right, we're going to start out by talking about hyponatremia. And I want you guys to tell me in the chat box what are some causes of hyponatremia? We've got dehydration, um, flu vomiting, dehydration, those are big ones. I'm looking for, oh, SIADH. Yes, that's one of them. Fluid overload. Great job, you guys. You've hit a lot of the major causes of hyponatremia. And so let's jump into those specific causes. Now, hyponatremia can feel, and hypernatremia both can feel a little bit confusing sometimes because you have three different types of hyponatremia. You have euvolemic, you have hypervolemic, and you have hypovolemic. The causes, the treatments, everything's going to be slightly different based on what type of a situation you have. So let's talk first about euvolemic hyponatremia. With euvolemic hyponatremia, the water increases a little, but the sodium stays the same. So if we look at our normal water level as a half glass of water with a handful of sodium particles in there, with euvolemic hyponatremia, that water level has increased, but the basic number of sodium has stayed the same. The sodium is diluted, and that causes a relative decrease in sodium. And so let's look at some of the basic causes of euvolemic hyponatremia. A big one is SIADH. A few of you mentioned that in the chat. When you have too much antidiuretic hormone, you are holding on to your fluids. You're not peeing very much, you're retaining water, but the sodium level stays pretty much the same. So you have an increase, a small increase in fluids with the same sodium level. That gives a relative decrease in sodium, and it makes a client euvolemic hyponatremic. This can also be caused by adrenal insufficiency or Addison's disease with decreased aldosterone. Aldosterone is what is holding on to sodium, and so if your aldosterone levels are low, that's going to cause that hyponatremia. It can also be caused by polydipsia, excessive hypotonic IV fluids. So maybe we've given a client in the hospital too many hypotonic IV fluids, and they may become euvolemic hyponatremic. And also, if they have a low dietary intake of sodium, we might see this as well. So that is some of the causes of euvolemic hyponatremia. Now let's look at some of the causes of hypervolemic. We know hyper means high, high volume, high fluid volume. So with hypervolemic hyponatremia, rather than just having a half a glass of water like we have in this normal illustration, we have an entire bucket of water. So we have a huge increase in water, but a similar number of sodium particles. And so we have that diluted effect with the sodium. So the client becomes hyponatremic. We most often see hypervolemic hyponatremia in organ failure. So we're going to see it in heart failure, kidney failure, liver failure. We may also see it in nephrotic syndrome and in water intoxication. All right, let's take a look at our final type of hyponatremia, which is our hypovolemic hyponatremia. This is where water and sodium are both lost. We often see this in situations with like nausea, vomiting, diarrhea, where the client is losing a lot of fluids. We might see this with a client who is receiving NG suction. This is why we typically don't allow clients who are having that NG suction to drink water, because sodium follows water. And so if we're doing that suctioning, it can drop those sodium levels. We also see this with diuretics, burns, and excessive sweating. So those are the basic causes of hyponatremia. Let's look at some assessment findings. So we mentioned before a little bit on this, but neuro is the number one thing I want you to think about anytime sodium levels are off. I like to remember this because the symbol for sodium is Na, and neuro is the primary affected system here. So anytime you have sodium changes high or low, Think neuro. Think changes in level of consciousness. Your client may start out acting a little bit confused, then they become lethargic, they develop a stupor. They may eventually progress to the point of cerebral edema, increased ICP. We may end up having some seizure activity. If our sodium levels are low enough, we're going to put our clients on seizure precautions. Does anyone know what number we're looking at for seizure precautions? What sodium level are we looking at? Less than 125 is typically what we're looking at for seizure precautions. Normal sodium is 135 to 145. If they drop down to 125, we are going to put those seizure precautions in place and really be keeping a close eye on that neural status for our client. We're also going to see some musculoskeletal changes. So we might see some weakness. Orthostatic hypotension is going to lead us to want to have some fall precautions in place, perhaps when those sodium levels are dropping. GIGU, we're going to see loss of appetite, hyperactive, bowel sounds, those types of things. That's kind of what we're looking at in the GIGU. CV changes, hypovolemia. The CV changes are going to depend on what the cause is. So if they have hypovolemic, hyponatremia, they have low blood volume. So you're going to see those symptoms of low blood volume, the weak pulse, the tachycardia, the hypotension, the dizziness, those types of symptoms. Hypervolemia, you're going to see bounding pulses. All right, so those are the assessment findings to keep an eye on for low sodium levels. There's this little mnemonic in the corner, low sodium, that can help you remember those assessment findings. All right, just a little quick plug here for our Sure Pass combo. This is our number one recommended package. The Sure Pass combo gives you everything you need to prepare for the NCLEX. It includes our on-demand video bank. It includes the Q bank. It includes the 3-day live review. It includes access to our live lectures. So everything is included to help you be successful on the NCLEX. And so if you're interested in purchasing the Short Pass combo, you can scan as an RN student, the code on the left, the code on the right is for our PN students. All right, so that is the Sure Pass combo. All right, let's talk a little bit about treatment with hyponatremia. Once again, treatment is going to depend on whether it is hypovolemic, hypervolemic, or euvolemic hyponatremia. With hypovolemic hyponatremia, we are going to treat that by restoring volume and sodium. And so typically that's going to be through IV fluids. If it's mild, they'll be getting NS. If it's severe, they'll be getting 3% NS. With hypervolemic or euvolemic hyponatremia, treatment's going to look just a little bit different. You are going to restrict free water and you're going to encourage high salt foods through their diet. They may be on osmotic diuretics and possibly sodium tablets. Let's take a look at what that diet might look like. This is one of the few situations as a nurse where you are encouraging a high salt diet. You are encouraging them to eat things that are canned, preserved, processed, because they are going to have those high sodium levels. It's always important as you are replacing sodium to keep an eye on that neural status, and you want to replace sodium slowly. I remember that by slowly starts with an S and sodium starts with an S. And so slow is the name of the game. Whether the sodium levels are high or low, you need to fix it slowly. So with hyponatremia, you're going to replace that sodium slowly. 0.5 milliequivalents per hour is what we're looking for as an ideal replacement. And if we do it too quickly, you're going to have that fluid shift and you're going to end up with cerebral edema and increased ICP. And we don't want to do that to our clients. All right, let's switch gears just a little bit and let's talk about hypernatremia, those high sodium levels. Tell me in the chat what can cause hypernatremia. Great job, you guys. I'm seeing some great answers here. DI is a big one, dehydration, diet. Those are all causes of hypernatremia. Once again, we have three different types of hypernatremia. The causes are going to vary. So if we are dealing with euvolemic hypernatremia, that is where we have minimal water and that gives a relative increase in sodium. So rather than that half glass of water, we've dropped down a little bit. But the sodium particles have stayed the same, so it gives you that relative increase in sodium. This can be caused by hyperventilation, excessive sweating, fever, and diabetes insipidus, which several of you mentioned in the chat. So DI can lead to that euvolemic hypernatremia. Hypervolemic hypernatremia is when you have an increase in both sodium and water. So rather than this half glass of water with a little bit of sodium, you have the entire bucket full of water and you have lots and lots of sodium within that bucket. So you have that increase in both. We see this with hypertonic IV fluids. If someone has received too many hypertonic IV fluids, we may see that hypervolemic hypernatremia. Sodium bicarbonate can cause this. Increased sodium intake. We see it with corticosteroids and Cushing's disease as well, and hyperaldosteronism. So those are all things that might cause your hypervolemic hypernatremia. And then finally, hypovolemic hypernatremia. This is where the water level is decreased significantly. So rather than a half a glass of water, your cup is empty and you have sodium still in there. So you have decreased water and sodium, but you have more water loss. So it puts the client in a hypovolemic state. The loss of the fluids leads to a relative increase in the amount of sodium in the blood. And so that is why it is hypovolemic hypernatremia. This is primarily caused by dehydration. So someone who's been experiencing a lot of diarrhea, vomiting, maybe they're NPO for too long, they have burns or perhaps diuretics have caused that flush of fluids from their body. So those are your causes of hypernatremia. Let's talk about our assessment findings. Once again, neuro is going to be the big thing that we are watching. Whether sodium is high or sodium is low, we keep an eye on neuro. And we may see initially our client becomes restless. They get agitated, lethargic, drowsy. It progresses to stupor and even to a coma. Musculoskeletal. We are going to see overactivity in the muscles because of those high sodium levels. So you might see twitching and cramping and weakness. Your cardiovascular symptoms, again, are going to vary based on if the client is hypervolemic or hypovolemic. Hypervolemic, of course, you're going to have edema, hypertension, bounding pulses. Hypovolemic, you're going to have hypotension and weak pulses. And then your other symptoms are similar to what you would expect in someone who's dehydrated. You have that flushed skin, you have decreased urine output, you have the dry mouth. If you remember this mnemonic, fried and salted, that can help you remember the signs and symptoms that go along with hypernatremia. All right, let's talk about the treatment of hypernatremia now. Treatment, once again, is going to vary on the cause of the hypernatremia. So if you have a client who has euvolemic hypernatremia, you will be giving free water. PO is going to be the best way to get those sodium levels down. With hypervolemic hypernatremia, you want to fix the cause, figure out why they are experiencing the hypervolemic hypernatremia and fix the problem. And you are also going to be administering free water in this situation. And then finally, with hypovolemic hypernatremia, you are going to give isotonic fluids. And so that's your basic treatment with hypernatremia. You want to be monitoring neuro status always. Anytime you're messing with sodium, watch that neuro status. You need to correct it slowly. Just like we talked about with hyponatremia, hypernatremia also needs a very slow correction because you have that risk for cerebral edema. All right, before we go on with the our discussion, I want to just give a little plug for our small group tutoring. This is where you get the biggest bang for your buck at Archer. You have an hour with a tutor and a small group of students, and you will be discussing a specific topic. Maybe you'll be doing prioritization, testing strategies, pharmacology, and we have a huge list of small group tutoring sessions that we provide. But you get that time with a tutor with a very small group of students, so you can ask questions, you can interact. You'll do practice questions together. And it's only $25 for an hour-long session. You can scan this QR code for more information on how to sign up for our small group tutoring sessions. All right, that concludes our discussion on sodium. Now we're going to move on to that second electrolyte that we mentioned at the beginning, which is potassium. Potassium is the most abundant intracellular cation. Intracellular means that potassium is primarily found inside the cells rather than in the serum. And for that reason, our normal potassium levels are significantly lower than what we see with the normal sodium levels. Sodium was 135 to 145, potassium is 3.5 to 5.0 because it's mostly inside your cells. It is also a cation, which means it has that positive cell. Potassium is responsible for the nerve impulse conduction. It is an important in muscle contraction. The main thing I want you to think about with potassium is the heart muscle. Muscle contraction is the number one thing it does. The heart is the most important muscle you have in your body. So anytime potassium levels are off, high or low, we are going to think cardiac. We're going to keep an eye on that heart and make sure we're not developing a dysrhythmia. It's also very important in acid-base balances. And so if you are in acidosis, potassium is going to leak out of those cells, and that is going to cause an increase in the serum potassium. So we also keep a close eye on potassium anytime we've got an acid-base issue with a client. All right, let's talk hypokalemia now. Tell me, what are some causes of hypokalemia? Tell me in the chat box, what are some causes of hypokalemia? I see Cushing's, I see vomiting, diarrhea, different medications. Absolutely. You guys are right on track with this. So causes of hypokalemia can be remembered with this mnemonic of ditch. D is for drugs. There's specific drugs that cause a drop in potassium. So laxatives are one, especially K-exolate. That's a laxative that causes you to really lose a lot of potassium. There are specific diuretics that are going to, those loop diuretics, furosemide, are going to drop your potassium levels. Corticosteroids are going to lead to a drop in potassium as well. I is for inadequate potassium intake. Someone who's NPO, who has a poor diet, who's anorexic or bulimic, those eating disorders can cause that drop in potassium. Alcoholism, that's one that the NCLEX likes to test you on. Alcoholism, for the first issue here is the decreased dietary intake. Someone who's an alcoholic is usually not eating, they're drinking all the time, they're not getting the dietary intake of potassium, and then that alcohol causes inflammation in the GI tract, and that leads to poor absorption. So even what they are eating is not well absorbed, and so we often see those drop in potassium levels with someone who's an alcoholic. T is for too much water, so polydipsia, excessive IVF, excessive IV fluids. Those are all things that can lead to low potassium levels as well. We see it with Cushing's syndrome, C for Cushing's syndrome. With Cushing's syndrome, they are retaining water and sodium. That causes them to secrete potassium. It's due to those cortisol levels, and so we see that drop in potassium with Cushing's. We can also see it with heavy fluid loss. So someone who, once again, the NG tube suctioning that we mentioned when we were talking about sodium, someone who's having a lot of vomiting, diarrhea, they're just losing those fluids, wound drainage, sweating. Those are all things that are going to lead to hypokalemia. We've got two other causes that don't really fit into our mnemonic. One is alkalosis. We talked about acidosis at the beginning, but with alkalosis, that potassium is trapped in the cells. And so we have the lower serum potassium levels. And then hyperinsulinism is another cause of hypokalemia. Insulin opens up the pathways into the cell so that glucose can be pulled into the cell. It also pulls potassium into the cell. And so if someone has high insulin levels, they often have low potassium. All right, those are our causes of hypokalemia. Let's talk about assessment. What signs and symptoms are we going to see in our client with a low potassium level? If you can remember these 6 L's, it's going to help you remember. And remember L for low. The 6 L's, a client is going to be lethargic. They will have low and shallow respirations, limp muscles, lethal dysrhythmias, leg cramps, and lots of urine output. The one I really want you to focus on is those lethal dysrhythmias. Like I mentioned at the beginning, potassium primarily affects the heart. And so you need to be familiar with the lethal dysrhythmias and you need to be watching for those anytime you have a client with low potassium levels. Let's take a look at what that looks like on the EKG. So on your EKG, there are a couple of things I want you to keep in mind with your low potassium. The two specific changes that are just seen with low potassium is the prominent U wave and the flat and shallow or inverted T wave. So this U wave, this is an extra little wave that pops up at the end of that EKG that we just see with low potassium. That is called a prominent U wave. That is a sure sign that someone has low potassium. The other one is the flat, shallow, or inverted T wave. That T wave is either flattened out or it's inverted. So think about when the potassium is low, the T wave is low. So those are two things specific to low potassium. Couple of other changes that we also see here is the prolonged PR and the ST depression. We see those two whether potassium is high or low. So if you see prolonged PR or ST depression, you start thinking potassium, but you've got to look for that inverted T wave or the U wave to know that it's a low potassium that you're dealing with. All right, let's talk about treatment for low potassium. If they don't have enough potassium, we've got to give them more. And so the treatment is going to be focusing on getting more potassium into the body. First of all, we're always going to have them on telemetry with potassium changes so that we can keep an eye on what that heart is doing. We're going to hold loop diuretics, other potassium wasting drugs, because we don't want their body getting rid of more potassium if they're already low. We're also going to hold digoxin. Why would we hold digoxin? Tell me in the chat. Why would that be important to do with low potassium levels? Toxicity, thank you. Low potassium can lead to digoxin toxicity. And so that's why we hold digoxin. We do not want them to become toxic on it. So there's 3 ways that we can replace potassium for a client. First of all is a diet rich in potassium. It's a little hard sometimes to get enough potassium through the diet, but that's a great place to start. We can also give oral potassium supplements. These cause a lot of GI upset, so they're not really ideal, but it is an option. And then finally, you can do IV potassium supplements, but you need to be very, very cautious with those IV supplements. We never give potassium IV push. Who knows why? Tell me in the chat. Why would we never give IV push potassium? What would happen to the heart if we did? Yeah, it would stop the heart. We do not want to do that to our client. So potassium is only given slowly as a secondary piggyback. It's given preferably through a central line. We prefer not to even do it through a peripheral IV. We prefer the central line, and it needs to be given slowly. You need to monitor that IV site very carefully. It is a vesicant, and so it can cause phlebitis. It can cause extravasation. You can end up with a situation like this if you're not careful. So be very, very cautious with IV potassium. Here's a list of potassium-rich foods if your client needs that increase in their potassium levels. These are some foods you can recommend. All right, a real quick plug for private tutoring. This is one-on-one time with the tutor. We have all of our tutors are amazing. Every last one of them will do a great job for you. It's $75 an hour, $40 for a half an hour session, and the agenda is up to you. They can create a personalized plan for you. They can look over your scores and help you understand where your strengths and weaknesses are and what you need to do to improve those scores. They can help you know if you're ready to test or if you should take a little more time. They can review difficult topics with you. So this QR code here will help you learn more about our private tutoring offerings. All right, we are almost out of time, so I'm going to skip asking the question about hyperkalemia, and I'm just going to tell you all about it. Hyperkalemia causes. This is caused by too much potassium moving from the cells to the extracellular. And so that raises those serum potassium levels. This can often happen through burns, tissue damage, diabetic ketoacidosis. Those are situations that move that potassium from the intracellulars to the extracellular space. You might just have too much total potassium. Maybe the client is a renal failure or they've had excessive potassium intake and just that overall potassium level has gone up. And it can be caused by medications, ACE inhibitor, potassium sparing diuretics. Those are things that can lead to an increased potassium level. Assessment. What are we going to see in our client who has high potassium levels? They're going to have muscle weakness. We talked about how potassium primarily controls those muscles, and so muscle weakness is going to be a symptom that potassium is high. They might have some numbness, shallow respirations, because that diaphragm is just a big muscle, right? And it's having a hard time. It's weak. It's not doing its job to help the client breathe. The big thing we're going to see here is impaired contractility in the heart. Remember, we always think cardiac with potassium, and so they may have weak pulses, bradycardia, hypotension. We're going to see some definite EKG changes. Let's see what that looks like with hyperkalemia. So the two things I want you to watch for with hyperkalemia is the tall peaked T wave and the widened QRS. Those are the two that are specific to high potassium levels. So look at this T wave. It is huge. Remember, when potassium is high, the T wave is high. So you have that tall peaked T wave and you have the widened QRS. Those are the two specific findings that we see with high potassium. You are also going to see the prolonged PR and the ST depression. That is similar with hypokalemia. So that those two just show you there's something going on with potassium. But once you see that tall peak T wave, the widened QRS, you know you're dealing with hyperkalemia. This can lead to heart block, VFib, eventually it can lead to cardiac arrest. So this is something we don't want to ignore and we need to act on. So treatment of hyperkalemia, the interventions are going to depend based on the severity and the symptoms present, but we're always going to have our client monitored. We're going to be watching that EKG to make sure we are not developing a deadly dysrhythmia. We're going to discontinue any potassium supplements. So are they on IV potassium? Are they on PO supplements? Anything like that should be discontinued. We want to put them on a potassium restricted diet. We're going to give them IV calcium gluconate. Now, why would we give that? What does that have to do with high potassium levels? Yes, it is cardioprotective. Thank you, Sonia. Absolutely. It really doesn't have anything to do with potassium in and of itself, but it is going to protect the myocardium from fatal dysrhythmia. So it's going to help protect that heart. There are a couple of ways that we can treat hyperkalemia. The first one is to drive the potassium into the cells. We talked about this a little bit before, but insulin helps drive potassium into the cells. So you can give the client D5W to keep those blood sugar levels up and regular insulin, and that's going to help drive that potassium into the cells. You can give them albuterol and bicarbonate. Those both help drive it into the cells as well. Another method of treatment is to reduce the total body potassium. So Oxalate, that's a laxative. It's going to have them get rid of that potassium through the stools. Diuretics are going to help them get rid of the potassium through the urine. So things like hydrochlorothiazide and furosemide will be given. Kind of the last ditch treatment when the other items aren't working and the client has severe hyperkalemia, we may use dialysis to treat that hyperkalemia. All right, just a little mnemonic here. CRIDE can help you remember the hyperkalemia management. We can give that calcium, we can remove sources of potassium, increase potassium excretion, enhance potassium uptake in the cells, and finally, we can try dialysis. All right, just a little comparison of potassium with hyperkalemia versus hypokalemia in the EKG. When the potassium is high, you have that tall peak T wave and the widened QRS. When potassium is low, you have the shallow T wave and the prominent U wave. So make sure you know those two specific changes that are present in the EKG for potassium. All right. And just as a little, one last little plug for Archer, I just want to remind you guys that we are here to support you through your nursing journey every step of the way. We have pre-nursing programs that can help you with those nursing school entrance exams. We have nursing school modules that can help you through nursing school if you're struggling with specific semesters and specific topics of study. We have our NCLEX prep packages for both PN and RN students. And finally, we even support the nurse practitioner and have products to help you along that path to becoming a nurse practitioner. Just want you to know that Archer Review is more than just a test prep company. We are your dedicated team of knowledge navigators. We are committed to your success as future nurses. Please trust us to guide and support you every step of the way on your nursing journey. I want to thank all of you for joining today. I've enjoyed sharing a little bit about fluids and electrolytes with you. And if you've got our SurePass program, you can go into our on-demand videos and learn more about fluids and electrolytes through those on-demand videos. We just kind of had that nice little introduction today. Hopefully you're feeling a little more confident in your knowledge level in sodium and potassium. Thank you, everyone, and I hope to see you around Archer in the future.